So students, let's now start with chapter 56 of your Apurba Sastry Essentials of Microbiology, which is about viral exanthems and other cutaneous viral infections. In this chapter, we'll be previewing herpes infections, herpes simplex virus infection, varicella zoster virus infection, parvovirus infection, human papilloma virus infection, pox virus infection, measles, rubella, hand, foot and mouth disease. Okay, so in this video, we'll be covering the herpes simplex and varicella zoster virus, while these other infections will be covered in the subsequent videos. An exanthem is an eruption or rash on the skin that may be associated with fever or other systematic symptoms. Majority of exanthems have infectious etiology, most commonly by viruses. Exanthems may also be seen due to drug reactions. The viruses that can cause exanthematous and other type of skin lesions include herpes virus, herpes simplex virus, varicella zoster virus, rarely Epstein-Barr virus secondary to ampicillin therapy, and HHV6 and HHV7 infection. DNA viruses other than herpes virus such as smallpox virus, parvovirus, and human papilloma virus. RNA virus such as measles, rubella, and Coxsackie virus. Exanthematous rashes are also a common feature of viral hemorrhagic fever discussed in later chapters. Viral exanthems and other cutaneous viral infections. Viruses, herpes virus, herpes simplex causes vesicular lesions. Varicella zoster virus causes chickenpox and zoster. Epstein-Barr virus causes exanthems following ampicillin therapy. Human herpes virus 6 causes roseola infantum, exanthems subitum or sixth disease. Okay. Other DNA viruses like pox virus called smallpox and molluscum contagiosum. Parvovirus cause erythema infectiosum, fifth disease, and purpuric glove and sock syndrome. Human papilloma virus HPV causes warts, common warts, flat warts, plantar warts, anogenital warts, condyloma acuminatum. RNA viruses, measles virus causes rashes, Koplik spots, rubella virus cause rashes, Coxsackie virus causes hand, foot, mouth disease. Agents of viral hemorrhagic fever cause dengue, Ebola, and others. Okay, now coming on to herpes virus infections. General properties. Herpes viridae comprises of a group of viruses that possess a unique property of establishing latent or persistent infections in their host and later on undergoing periodic reactivation. Morphology. Herpes virus are large, 150 to 200 nm size, spherical in shape with icosahedral symmetry. Nucleocapsid possess a linear dsDNA surrounded by a capsid comprising of capsomeres. Envelope. The nucleocapsid is surrounded by a lipid envelope into which glycoprotein spikes are inserted, which help in viral entry by binding to the specific host cell receptors. Tegument. Between the capsid and envelope, there is an amorphous, sometimes asymmetric structure present called tegument. In this figure, we can see the schematic diagram of herpes simplex virus. From outside to inside, we have glycoprotein spikes and lipid, which constitute the envelope. Then we have tegument. Inside, we have icosahedral capsid, which contains a linear double-stranded DNA. Now, classification of human herpes virus, family herpes viridae. Subfamily alpha duration of replication is short, 12 to 18 hours, and it is cytolytic. Site of latency neuron. Genus simplex virus cause human herpes virus 1 with the common name herpes simplex virus type 1. Human herpes virus 2, common name herpes simplex virus type 2. Varicelloviruses genus contain human herpes virus 3, common name varicella zoster virus. Now subfamily beta. Duration of replication long, more than 24 hours, and it is cytomegalic. Site of latency is glands and kidneys. Genus cytomegalovirus. Official name human herpes virus 5. Common name cytomegalovirus. Now other one, long, more than 24 hours, lymphoproliferative. Site of latency lymphoid tissues, T cells. Genus roseellovirus. Contains human herpes virus 6 with the same common name, and human herpes virus 7 also with the same common name. Gamma subfamily. Duration of replication is variable and it is lymphoproliferative. Site of latency lymphoid tissues, B cells. Genus lymphocryptovirus, human herpes virus 4, common name Epstein-Barr virus, and radenovirus, human herpes virus 8, common name Kaposi sarcoma associated herpes virus. Now, replication of herpes virus takes place in the host cell nucleus and is similar to replication of any other dsDNA virus as described. The only difference is that linear dsDNA of herpes virus becomes circular inside the host cell and then replicates by rolling circle mechanism. Classification. Family herpes viridae comprises of three subfamilies alpha, beta, and gamma, classified based on the site of latency, duration of growth, cycle, and type of cytopathology they produce. Each subfamily in turn has one or more genera, and each genus consists of a few species. For general use, the common names are still popular, which are also followed in this textbook. There are about 100 herpes viruses infecting different animals, out of which only 8 are human herpes virus, which infect exclusively man. Herpes simplex virus infections. Herpes simplex virus belong to alpha subfamily of herpes viridae. They are extremely widespread and exhibit a broad host range, can infect many types of cells and infect and different animals. However, the human herpes virus infect exclusively man. They replicate fast, 12 to 18 hours cycle, spread fast, and are cytolytic. They can cause a spectrum of diseases involving skin, mucosa, and various organs. They undergo latency in nerve cells, reactivate later, causing recurrent lesions. Herpes simplex virus (HSV) are of two distinct types, HSV1 and HSV2. They differ from each other in many aspects. Pathogenesis. Primary infection transmission occurs through abraded skin or mucosa from any site, but more commonly by HSV1 oropharyngeal contact with infected saliva or direct skin contact. HSV2 sexual contact or rarely vertical mode from mother to fetus. Site of infection. HSV replicates at the local site of infection and produces lesions anywhere, but more commonly in HSV1 lesions are confined to areas above the waist, most common site around mouth. HSV2 produces lesions below the waist, most common site genital area. Spread via nerve. Viruses then invade the local nerve endings and it is transported by retrograde axonal flow to the dorsal root ganglia where it replicates further and then undergoes latency. Primary HSV infections are usually mild, in fact, most are asymptomatic. However, in immunocompromised hosts, viremia occurs that leads to widespread organ involvement and systemic manifestations. Latent infection. HSV has a tendency to undergo latency in neurons. HSV1 undergoes latency in trigeminal ganglia, while HSV2 undergoes latency in sacral ganglia. HSV does not replicate in latent stages and cannot be isolated during latency. Recurrent infections. Reactivation of the latent viruses can occur following various provocative stimuli such as fever, axonal injury, physical or emotional stress, and exposure to ultraviolet light. Via the axonal spread, viruses go back to the peripheral site and further replicates in skin or mucosa, producing secondary lesions. Recurrent infections are less extensive and less severe because of presence of pre-existing host immunity that limits the local viral replication. Recurrent infections are usually asymptomatic, but the virus continues to shed in the secretions. Clinical manifestation. Both HSV1 and 2 have been isolated from nearly all mucocutaneous sites and viscera. However, in general, oral facial infections are common with HSV1, whereas HSV2 frequently causes genital infections and intrauterine infections. The incubation period ranges from 1 to 26 days, median 6 to 8 days. Oral facial mucosal lesions. Oral facial mucosal lesions are the most common manifestations of HSV infections. Most common affected site is buccal mucosa. Most frequently primary lesions are gingivostomatitis and pharyngitis. Most frequent recurrent lesion is herpes labialis, painful vesicles near lips. Other lesions produced are ulcerative stomatitis, tonsillitis, and vesicular lesions on the eyelids. Many cases are asymptomatic but can predispose to secondary bacterial infection. Now, vesicular lesions on the lips can be seen in figure A and tongue due to the HSV1 infection, while the periocular vesicular lesions due to HSV1 infection can be seen in the figure 2. Now coming on to cutaneous lesions, HSV usually infects through abraded skin and causes various cutaneous lesions. Herpetic whitlow. Lesions present on the fingers of dentists and hospital personnel. Febrile blisters, herpes fibrilis, fever due to any other can provocate HSV to cause recurrent blisters. Herpes glandiatorum, mucocutaneous lesions present on the body of wrestlers. Skin lesions are often severe on underlying eczema or burns, which permit extensive local viral replication and spread. Eczema herpeticum, caused by HSV1 in patients with chronic eczema. Similar lesions are also produced by vaccinia virus or Coxsackie virus. A16 infection. These conditions together are designated as Kaposi varicellum eruptions, varicelliform eruptions. Erythema multiforme (HSV) is commonly associated with this condition. Herpes antigens have been detected in the immune complexes found in the serum or skin biopsies. Other infective syndromes of HSV: CNS infections. HSV causes various neurological manifestations such as encephalitis, meningitis, Bell's palsy due to facial nerve involvement, etc. Ocular manifestation: HSV causes various ocular manifestations such as keratoconjunctivitis, corneal ulcer, and blindness. Genital lesions: HSV2 is more common than HSV1 due to produce genital lesions described as bilateral, painful, multiple tiny vascular ulcers. Visceral and disseminated herpes. HSV viremia results in disseminated infection involving multiple organs. Risk factors: immunocompromised patients, underlying malnutrition or AIDS, pregnant women, and transplant recipients are at higher risk of disseminated infection. Common manifestations include pneumonitis, tracheobronchitis, and hepatitis. Neonatal herpes. Transmission is more common during birth than in utero. Neonates are almost always symptomatic and present with either local lesions or disseminated infection or CNS infection. Epidemiology. Herpes simplex virus are worldwide in distribution. No animal reservoir or vector are involved with the human viruses. HSV 1 and 2 differ in their epidemiological pattern. Epidemiological pattern of HSV1 transmission. HSV1 infection is more common and is transmitted by contact with infected secretions like saliva. Primary infection occurs early in life and is either asymptomatic or remains confined to oropharyngeal disease. Age. Children are commonly affected. Adults, antibodies develop in 70 to 90% of the adults, but they fail to eliminate the virus from the body. Most adults become carriers throughout their life, occasionally get transient recurrent attacks. Epidemiological pattern of HSV2. HSV2 is transmitted by sexual or vertical routes. Primary infection occurs in adult life. Antibodies develop only in 20% of the people, particularly among black women than men and whites. HSV2 tends to reoccur more often than HSV1 irrespective of the site of infection. HSV infection lab diagnosis. Cytopathology: Tasnac preparation by Wright's or Jimsa stain detects inclusion bodies, Lipschul's body, and formation of multinucleated giant cells. Virus isolation by conventional cell lines used to demonstrate diffused rounding and ballooning of cell lines. Shell viral culture detects antigens in cell line by IF. Immunofluorescence. Viral antigen detection in specimen by direct IF. HSV DNA detection by PCR and real-time PCR detecting glycoprotein B and UL30 genes. Antibody detection by ELISA or other formats detecting antibodies to glycoprotein G. Lab diagnosis. The sensitivity of all the methods to diagnose HSV infection depends on the type of specimen as well as the type of infection. The sensitivity is more for vesicular lesions and primary infection than for ulcerative lesions and recurrent infections. Cytopathology. Scrapings obtained from the base of the lesion can be stained with Wright's or Jimsa Tasnac preparation or Pani-Koleau stain. Sensitivity of staining is low, less than 30% for mucosal swabs. It cannot differentiate between HSV1 and HSV2 and varicella zoster viruses, as all of them produce similar but characteristic cytopathological changes such as production of Cowdry type A intranuclear inclusion bodies, Lipschul's body, formation of multinucleated giant cells with fasciated nuclei and ground glass chromatin, Tasnac cells. Ballooning of infected cells, margination of chromatin. Virus isolation. It remains the most definitive tool for HSV diagnosis. McCoy cell lines are preferred for isolation of HSV. Viral growth can be detected in 2 to 4 days by characteristic cytopathic effect, diffuse rounding and ballooning of the infected cells, viral antigen detection by neutralization test or immunofluorescence staining with specific antiserum. Shell viral technique can be followed to decrease the detection of time to less than 24 hours. In these figures, we can see Tasnac smear of a tissue scraping showing multinucleated giant cells in the center. And in figure B, we can see indirect IF or HSV1 or 2 antibody detection. Okay. Now, viral antigen detection by immunofluorescence. Viral antigen detection targeting cell surface glycoprotein antigens by direct IF is also a sensitive and specific assay. It can differentiate HSV1 from HSV2. HSV DNA detection. Polymerase chain reaction PCR is the most sensitive test for detecting HSV infections and can be used to differentiate between HSV1 and HSV2. Real-time PCR has been developed targeting genes such as glycoprotein B and UL30, which are more sensitive, can quantitate the viral load in specimens, prognostic marker of HSV encephalitis, and also can differentiate between HSV1 and 2. The BioFire film array is an automated nested multiplex PCR. Its meningitis encephalitis ME panel can detect simultaneously 14 microbial pathogens causing CNS infections, including HSV1 and HSV2. Antibody detection. Antibodies appear in 4 to 7 days after the infection and peak within 2 to 4 weeks. IgM appears first and is replaced by IgG, which persists for life. Most available tests usually detect IgG or total antibodies, hence cannot differentiate between recent and past infections. Seroconversion or a rise in titer is more meaningful. Serologic assays, example ELISA, based on the type-specific antigens such as glycoprotein G antigens, small g capital G1 and small g capital G2, can differentiate between HSV1 and HSV2. Western blot is more accurate with 98% sensitivity and specificity. Both ELISA and indirect IF formats are available. Now, treatment of HSV infections. Several specific antiviral drugs are effective for HSV infections. Acyclovir is the drug of choice. It acts by inhibiting viral DNA polymerase. For mucocutaneous infections, acyclovir, famiciclovir, and valacyclovir have been the mainstay of treatment. Ocular infection, topical idoxuridine, uh, trifluorothymidine, topical vidabarine, and cidofovir are used. For HSV encephalitis and neonatal herpes, acyclovir is the treatment of choice. Acyclovir resistance has been reported among few HSV strains which have altered substrate specificity for phosphorylating acyclovir. Resistance is more common in HSV2 and among immunocompromised patients. Foscarnet is the drug of choice to treat such cases. Prevention. General measures can be taken such as use of condom to prevent genital herpes. Neonatal herpes can be prevented by prior administration of acyclovir to mothers during third trimester of pregnancy or delivery by elective cesarean section. No vaccine is currently licensed. Several vaccine trials are going on, such as recombinant HSV2 glycoprotein vaccine. Infection control measures. Patients with mucocutaneous herpes in hospital should be kept on contact precautions until lesions are dry and crusted. Now coming on to varicella zoster infections. Varicella zoster VZV produces vesicular eruptions, rashes on the skin and mucous membrane in the form of two clinical entities. Chickenpox. It is characterized by generalized diffuse bilateral vesicular rashes which occur following primary infection, usually affecting children. Zoster or shingles. It occurs following reactivation of latent VZV present in trigeminal ganglia that occurs mainly in adult life. Vesicular rashes are unilateral and segmental, confined to the skin, innervated by single sensory ganglion. Chickenpox. Pathogenesis VZV enters through the upper respiratory mucosa or the conjunctiva by aerosol, most common, and contact transmission. From the local site, it spills over to blood and then is carried through the infected mononuclear cells to target sites such as skin, produces rashes, respiratory tract, shed in respiratory secretions, neurons undergoes latency. Clinical manifestations. Incubation period is about 10 to 21 days, 2 to 3 weeks. Rashes are the main manifestation of chickenpox. Rashes are vesicular, centripetal in distribution, usually start on the face and trunk, spread rapidly to involve flexor surfaces, sparing distal parts of the limbs. Bilateral and diffuse in distribution, rashes appear in multiple crops, lesions in various stages of evolution such as maculopapules, vesicles, pustules, and scabs can form in one area at the same time. Fever appears with each crop of rashes. Chickenpox is a disease of childhood. As we can see in figure A, we can see the rashes of chickenpox. In figure B and C, we see the segmental distribution of the rashes of zoster. When occurs in adults, it is more severe with bullous and hemorrhagic rashes, leaving behind pitted scars or skin after recovery. Complications. Complications are more common in adults and in immunocompromised individuals. Most common infections complication is secondary bacterial infections of the skin. Most common extracutaneous complication is CNS involvement, cerebellar ataxia, encephalitis, and aseptic meningitis usually occurs in children. Most serious complication is varicella pneumonia, which develops most commonly in adults, up to 20% of the cases, than in children, and is particularly severe in pregnant women. Race syndrome can occur secondary to VZV infection. It is characterized by fatty degeneration of liver following salicylate aspirin intake. Other complications are myocarditis, nephritis, corneal lesion, and arthritis. Chickenpox in pregnancy. Chickenpox in pregnancy can affect both mother and the fetus. Mothers are at high risk of developing varicella pneumonia. Fetus is at high risk of developing congenital varicella syndrome in early pregnancy, characterized by cicatricial skin lesions and limb hypoplasia. Epidemiology. Chickenpox is a highly contagious disease, primarily a disease of temperate regions, occurs throughout the year with a prevalence of 13 to 16 per 1000 people per year. Age common children aged between 1 to 14 years of age. Period of infectivity child is infectious from 2 days before the onset of rash to 5 days thereafter until the vesicles are crusted. One attack gives lifelong immunity. Reservoir humans are the only reservoir host. Source of infection patients are the only source. There are no carriers. Secondary attack rate is about 70 to 90%. Zoster or shingles or zona. Zoster usually occurs due to the reactivation of latent VZV in old age more than 60 years of age, in immunocompromised individuals or occasionally in healthy adults. It usually starts with severe pain in the area of skin or mucosa, supplied by one or more groups of sensory nerves and ganglia. Rashes, they are unilateral and segmental, confined to the area and skin supplied by the affected nerves. Most common nerves involved is the ophthalmic branch of trigeminal nerve. Head, neck, and trunk are the most common affected sites. Complications of zoster. Post-herpetic neuralgia, pain in the local site lasting for months, is the most common complication in elderly patients. Zoster ophthalmicus. Unilateral painful crops of skin rashes surrounding the eye. Ramsay-Hunt syndrome develops when geniculate ganglion of facial nerves is involved. It is characterized by a triad of ipsilateral facial paralysis, ear pain and vesicles on the face, tympanic membrane and external auditory meatus. Visceral disease, especially pneumonia, can occur, which is most common cause of death, less than 1% in zoster patients. Recurrent or chronic zoster is common with HIV infected patients. Lab diagnosis of VZV. Lab diagnosis of VZV infection is as follows. Specimen collection. Common specimens include vesicular lesions, scabs, and maculopapular lesions. Cytopathology. Zimsa staining of the scrapings from the ulcer base. Tasnak smear reveals cytopathological changes similar to that of HSV infection, such as formation of multinucleated giant cells. Virus isolation in various cell lines can also produce HSV-like cytopathic effects, such as diffuse rounding and ballooning of the infected cells. VZB specific methods: specific antigen detection by direct immunofluorescence staining, specific IgM and IgG antibody detection by ELISA, PCR detecting VZV specific genes. The Biofire Meningitis Encephalitis ME panel tests simultaneously 14 microbial pathogens causing CNS infections, including VZV. Treatment of VZV infections: acyclovir, famiciclovir, or valacyclovir are the agents of choice. It can prevent the complication of chickenpox, can also halt the progression of zoster in adults, but cannot prevent post-herpetic neuralgia. Vaccine. Live attenuated vaccine using Oka strain of VZV is available. It is given to children after 1 year of age. 2 doses. First dose is given at 12 to 15 months and second at 4 to 6 years. In seronegative adults, 2 doses given at 1 month gap. As this vaccine is not being given as a part of national immunization schedule, the countrywide vaccine coverage is inadequate, leading to frequent outbreaks. Transmission of the vaccine virus can occasionally cause mild rashes in the recipient. Protectivity: vaccine is more than 80% effective in preventing chickenpox in children but less so in adults. However, it is 95% in preventing severe disease. VZIG, varicella zoster immunoglobulin. It is useful for post-exposure prophylaxis given within 96 hours, preferably within 72 hours of exposure. As adults are at high risk of varicella-related deaths, VZIG is recommended for adults, especially those who are at greater risk of complications, immunocompromised persons such as HIV, pregnancy, etc. It is also indicated for neonates born to mothers suffering from chickenpox if the onset of chickenpox in the mother is between less than 5 days before delivery till 48 hours after delivery. VZIG is not indicated for the neonate if the mother has zoster. Infection control measures. Patient infected with VZV should be kept in isolation. Airborne precautions, example negative airflow rooms, plus contact precautions must be followed until regions are dry and crusted. For localized zoster in an immunocompetent host, local contact precaution alone can be followed. Other herpes virus infections. Other herpes virus infections include Epstein-Barr virus. EBV causes infectious mononucleosis and various malignancies. It can produce rashes following ampicillin therapy. Cytomegalovirus CMV cause congenital infection, also produces various infections in transplant recipients. Human herpes virus 6. It infects the T cells by binding to CD46 receptor. It has two variants, 6A and 6B. Transmission is through infected oral secretions. 6 disease in children, HHV6. Usually the 6B variant causes skin disease, also called as exanthem subitum or roseola infantum. It is characterized by high grade fever and skin rashes. In older age group, HHV6 has been associated with mononucleosis like syndrome. Human herpes virus 7 HHV7 also shows tropism for T cells transmitted by oral secretions, mainly in children. It shares 30 to 50% DNA homology with HHV6. It has been associated with fever, seizures, and respiratory or gastrointestinal symptoms, and pityriasis rosea. Human herpes virus 8, it causes malignancy called as Kaposi sarcoma in HIV infected individuals. Okay, so this completes part 1 of the chapter. Next part we'll cover in the next video. So like, share, subscribe. Thanks for watching.